and not her arms, and succeeded in breaking her arm and her elbow in multiple spots. Passed out first time. Then we went to Children's, of course, went through a long period of admission to the hospital, rehab, and so forth, and she kept passing out. So I said, well, something is not right. When we're on to high school, doing fairly well, and then she had mono in her second year of college, and from there on, we went through really a tough time with full-blown POTS, inability to stand up. She had to withdraw actually for over 6 months from college. She was in bed most of the time. She had to do cognitive therapy consistently, 2 to 3 times a week. Finally got better with beta blocker and medication. And now she's a successful engineer, living in London. Still, however, really affected by this whole syndrome. She was drawn to yoga and meditation, who has made a huge difference in her life. So what I really want to say as we start this conversation, and that is POTS and autonomic dysfunction is a very complex group of symptoms, group of autonomic abnormality that affects everybody. See which one. It is amazing. I was talking to one of my POTS friends here, and over 3 million people in America that are affected by this disease with a diagnosis known. So imagine the entire city of Boston, and everybody's walking around with POTS syndrome. There is a diagnosis that occurs of about 500,000 people a year. It's disabling. It affects not only the patient themselves, but the family, their friends, their job, and their ability to be productive in the community. So it finally, in 2011, made it into the Disability Act. So if adults with productive jobs are affected by this disease, and we know Brad will talk about it, please have your physicians and your people assist you in filling out disability forms so you are not feeling like there is no hope for you. And that's fundamental. I really believe that we need to do everything we can to have people enrolled in their own illness, and this is part of it. I also mentioned this because of the young adults that are getting ready to go to college, participating in intense activities. There are, according to the Disability Act, multiple accommodation changes that can be made. The kids can be placed on first floor of the college dorms. They can be given longer times to take tests. They are allowed to bring water and drinks into the classroom, which seems to be a big issue in high school. I just discovered that where I live, they are afraid the kids are going to bring alcohol in their water bottles. So they only want clear containers, but you can write a prescription for your young adult to be able to bring water into the classroom. So there are the diagnoses that we make, and they're mostly on physical ability. A lot of you probably already have tilt table test, which is the infamous table that goes up and down. A lot of people, when they see a tilt, they think they go upside down, but anyway, we don't go upside down. We have different standards for age groups. So for the kids to be diagnosed, they have to have a higher increase in heart rate than the adults, because they run faster heart rate at rest. So for the kids, we look for 40 beats or over 130 beats per minute. And there is a huge amount of symptoms, including the fogginess, which Brad was talking about, which is related to cerebral hyperperfusion, cognitive difficulty, blurred vision, and kids experience that quite often while they're up on tilt. They get really agitated, confused, and feel very, very, very uncomfortable. We also look at the older population with the symptoms called orthostatic intolerance. They don't quite meet the standard of the heart rate, but they have really a hard time standing up. Their onset of low blood pressure or change in heart rate occurs much more slower than the other patients. Dysautonomia is a big spectrum of diseases. So, as Brad was mentioning, there's a lot of comorbidity that are part of this dysautonomia umbrella. So you can have GI conditions, Crohn's, ulcerative colitis, celiac disease. Commonly, we see symptoms of heart and autonomic dysfunction associated with EDS, mast cell disorder, and quite often with deconditioning and diabetes. In fact, deconditioning is an amazing component to POTS. As you feel worse, the less you do, and the more the symptoms get aggravating. So you don't feel like getting up, and then that feeds into your deconditioning. Your muscle mass go down. The more you lay in bed, and the more your muscle mass go down. In a week in bed, you can lose 5% of your muscle mass. So even if you are on a horrible day, and there are some people that I know who have really a hard time getting out of bed, wheelchair, you have to do your isometric exercise. You have to put weights on your ankles, you need to go up and down on your legs, you need to lay on the floor, you have to do anything you can to maintain your muscle mass. Other things that I have discovered more recently as I changed my location is the ability of people to do extreme intense works but still be affected by this syndrome. We see a lot. I work and live in a military base now, and there is an enormous amount of kids that we see every day that have POTS and never known they had POTS. Did not talk to their recruiters about it. They didn't tell them they were feeling horrible after the day. They thought that going into the military was going to make a difference. And they were in training for 3 days and they start passing out. And that is hard for them. It makes them feel totally desperate. They had chosen a career without knowing that they can't do that career. You can't have syncope and drive a military truck. You can't be in high-risk job and have POTS. And then we see combat veterans. They come back who have been exposed to explosions, TBI, and TBI doesn't only mean people that have been in combat, but you could have had a motorcycle accident. You could have a car wreck. Somebody could have hit you from the back and be a rear end, and you can trigger symptoms of autonomic dysfunction. Because as Dr. Kinsella says, the brain, it's an amazing component of this syndrome. And just the heart is a secondary organ affected by it. The gut is a secondary organ affected by it. But it all starts with your autonomic control. When I try to explain autonomic dysfunction to patients, I always say, think about your body is like your house. You have a thermostat. And basically your thermostat is broken. You're never at the temperature that you're supposed to be set at. You're not at 37 degrees. Some days you're hot, some days you're cold. Your blood pressure is not always the same. It fluctuates. Your heart rate fluctuates. So your thermostat, by all measure, is not working correctly. And then the more you look into autonomic dysfunction, we see other conditions that are associated with the development of dysautonomia. Big surgeries, bariatric surgery. I kind of accidentally start discovering the association of autonomic dysfunction and bariatric surgery because of my practice. I used to work for SSM. We were associated with the Bariatric Institute, went to Tenet at a Bariatric Institute, and we start seeing all these people walking up with abnormal autonomic response. So then I started looking at some papers and some information in the literature, and even if you only see case reports, but there is no doubt that bariatric surgery is associated with dysautonomia. So even the patients that already have POTS and embark themselves into the bariatric surgery procedure, be aware that you can have a transit episode, a period of life where it gets worse. So it is part of how your body has to readjust to your new body. And again, the older patients, POTS is not really a diagnosis for them, but you do have orthotaxic intolerance, which can manifest the same way. However, in the patients that are older, you see orthostatin intolerance because of medications, because of Parkinson's, because of other neurological disorders that affect the way they stand. And you can see them and watch them. They can be standing for a blood pressure of 80 for a long period of time, and a POP patient wouldn't do that. And then all of a sudden they crash. So there, it's a much more, discrete way of developing the symptoms on a tilt table. A lot of you can relate to these symptoms, especially the hot and cold extremity, the sweating abnormality. Dr. Kinsella was talking about doing these tests in the autonomic lab. A lot of times, since we don't have an autonomic lab, I'll post, I really am very careful with the physical exam on these patients, especially the kids. They'll come in and they're totally vasoconstricted, their hands are sweaty, they tell me they're cold, and you know that they would probably belong to the hyperpots or hyperadrenergic pots. We have a lot of people that have digestive difficulty, poor appetite, bloating, diarrhea, irritable bowel syndrome, inability to absorb food, and we have had a couple of cases here in St. Louis where we had patients had to go on TPN for a period of times until there was a resolution of the GI symptoms. And that is extremely, difficult. It's extremely hard for a patient to walk around with a TPN bag. It's just a very limiting experience from the standpoint of the daily activity. One thing that people like is food. If you take away food, it makes it hard for anybody. And as Dr. Kinsella said, we really want to work on the quality of food that people with autonomic dysfunction eat, and go as much as you can toward the natural route. Get involved with community that have vegetables that are homegrown. Try to take away, don't even walk into the aisle of these stores that as I call plastic food. I've tried the experience myself. I put a bagel in my office on Valentine's. It was a red bagel, quote unquote, stained. That bagel was still alive and well in June, so God knows what was in there. It didn't mold, it didn't do anything. So, I don't even want to know about those other Kit Kat and various other things that kids, especially kids, love to have as a snack. So, we want to have a multifactorial approach. I am totally sharing with Brad the fact that the physician community has to be involved to acknowledge this condition. I still talk to a lot of primary care, and when you say POTS, they have no idea. There's also a big institution included, in this town that don't believe in POTS. And it's very limiting because you can't send patients to a university hospital someplace and they look at you like you're crazy. Oh, POTS doesn't exist. No, it does exist. And so, we really want to get this community in St. Louis expanded to Missouri. Fortunately, University of Kansas Medical Center, they are a strong believer in POTS. They have done work in POTS. They have worked with yoga and POTS. So there are communities within this area that are involved in the POTS. But it's an effort for all of us to bring awareness of this diagnosis, because you might want to have psychologists involved, behavioral therapists involved, yoga training classes, and even, as Brad was saying, gastroenterologists in this community. And of course, the primary cares. I know Dr. Kinsella does not believe in infusion therapy. It's still a very, conflicted form of therapy. But there is plenty of studies that demonstrated that, especially in people that want to maintain athletic activity and high-level activity, you have to give them infusions. I have started giving infusions to some of these active duty soldiers before the PT test. It is not recommended to do the day of your eye activity because really you don't have time to re-equilibrate. But if you know you're going to go away and hike for 2 days, you're going on vacation for a long weekend, those possibilities are there. And, we've been giving some infusion to Some of these kids who have to do a PT test, who know they're going to pass out when they run, and it's made a big difference. So we really want people to be functional. A lot of POTS patients have hypovolemia, and the volume is less, and if we measure by RBC volumes and total volume, so you can have as low as a lack of 25 to 30% volume status, which is a lot compared to a normal person. There's other forms of issues that you can see, the venous pooling, the neuropathy of the lower limbs, which affects even more the venous pooling. And these are the patients who really benefits from wearing support stockings, and other, the pants that I recommended for Brad, Under Armour and other company make them. You can reach the 30 millimeter pressure, and you should really be encouraged to wear them. I agree that some of these things are uncomfortable. I found a brand, especially for the older people that have difficulty bending over, that actually have zippers on the side of the compression socks. So it's easier for them to put them on, because all you have to go is past the foot, and then you zip it up. So women are more affected. Nobody knows why. I think it has to do partially with body mass, muscle mass, and things of that sort. There's also an issue with hormonal changes, change of volume during the menstrual period, and you can see that there's a lot of teenager girls that feel pretty bad in the time before their period. They also complain of elevated number of skip beats and palpitation and so forth. You have correlation with viral illnesses. As I mentioned, my daughter Rocky, it was a clear correlation with, and other GI symptoms, Coxsackie virus and GI viruses. There's been another girl that traveled through Mexico and contracted some odd GI disorder and then was affected by POTS for a long, long period of time. I saw a kid when I was still working at St. Mary's who went from being an athlete and a track runner to be very miserable after a summer where he contracted a GI virus. So be aware that something in your remote history has been affecting you. So as I mentioned, this vasoconstriction, venous pooling in the lower extremity affects a lot of POTS patients. The adrenergic POTS are the ones that we see a lot in the kids. We can have mixed pictures of peripheral vasoconstriction and pooling with hyperPOTS. It is not true that one POTS fits all. You can have multiple overlapping symptoms. If you suspect hyperadrenergic POTS, there is a way to measure catecholamine by blood test. It's expensive, and quite often you can make the diagnosis without it, but certainly, if you want to be very scientific, you can order pre and post adrenergic levels by blood test. The low flow POTS are less common. And the normal flow POTS are mostly patients that have TBI and physical deconditioning. So in those patients, the blood volume is not so much the factor, but it's the intracranial stimulation that affects the results. So the adrenergic tone exists in everybody, and POTS patient, as Brad showed in his very cute, picture. It's up 30 to 60% of the patient. You can see hypertensive response, and that's why we need an armamentarium of drugs for POTS patients. You almost have a pot of drugs, and you have all your little bottles that you use at different times. We have patients that have hyperPOTS, they shoot 200 systolic, the next day there are 80. So you have to be able to manage those days in order to have a steady state, or to get close to a 50% functionality of your day. this mast cell activation disorder. Some patients came to me way later into the diagnosis of POTS and found out that they did have mast cell activation syndrome. You know, if they were feeling flushed, they were having all these GI symptoms that came on suddenly, and sure enough, you know, as you correct the mast cell release, they feel better. So that's another group of drugs that if you are a mast cells release patient, you have to have in your little drugs armamentarium to take during those days. I already mentioned the infusion. If you are one of those people with low blood volume, you know, 3 liters of fluids a day. The salt supplements, we are very gracious that this company has offered us some of these new salt supplements. Some places like us on Post, the pharmacy will not sell salt tablets. They will sell also for sort of peddling products, which obviously you guys can't take, but they will not sell salt tablets. So these are ways to get the salt supplements online. You know, GNC has some other salt supplement, Crystal Light or similar stuff like Brett showed, but keep your blood volume up. If you have GI symptoms, that will aggravate your POTS symptoms, because if you start having nausea, vomiting, inability to absorb fluids, guess what? You become even more hypovolemic again. And that's the problem, especially in the summer. In the summer, you need vitamin. We all need vitamin. But patients with POTS have a huge issue with hypovolemia. So encourage everybody to carry a bottle, children, adults, carry around as much fluids as you can possibly do. And again, there are infusion centers that will accept prescription for periodic fluid infusion. We have several people that are supported by that. We have patients that have to be referred for placement of central access port catheters and PICC lines because of that. I try to discourage super young people to have greater access because of the possibility in the long term to develop occlusion of the vein. So if we can try with small volume and smaller catheter, that would be better. There is an infusion nursing society that has a lot of good advices. You have to become a member of it. If you're an associate member, I think it's $105. But there is a ton a year, and there's a ton of information about how to flush catheter, what to do with peripheral access, and so forth. So for the medical personnel who is involved in home care, long-term care of patients with catheter or cath, that's a very good source of information. We are starting an infusion center where we work because we've encountered that we have a lot of patients that persistently require, especially the active duty soldiers that need to go back in the field. And so we have started an infusion service and I'll be more involved with that part of the care. Why do POTS patients feel the way they do? Because there is actually documented process that will cause this visceral sensory information processing that builds up, and you become hypervigilant to your symptoms, like anything else. And then if you have had other situations like a trauma, a TBI, post-traumatic stress disorder, then you're already hypervigilant. So every little thing becomes amplified, and not because you're doing it malignantly, but because that's a response of your body. That's why meditation, breathing therapy, cognitive therapy, support groups are so crucial to patients with chronic illnesses, and POTS is a chronic illness. So be involved with each other, learn from each other, be grounded. I know it sounds silly, but spend some time of your day on the ground, on the floor. Attach your roots to the floor, to the ground. It's so important for patient POTS. Do your little silly exercises on the floor. There's nothing wrong with it. Pull out a yoga mat. watch a movie, but do your grounding exercise. It's crucial. It's really crucial. And the sleep disorders are frequently, very frequently associated with autonomic dysfunction. Nobody knows why, but part of it is the hypovigilance. Part of it is your brain goes 100 miles per hour at night, and then you can't concentrate during the day. So if you can't sleep, you need to try to do behavioral therapy, biofeedback, and other forms of therapy that will allow you to sleep. Yes, we can temporarily correct your sleeping disorder with Ambien, but you know, Ambien is not the cure. It's to bring your brain back down to a point where you are calm, where you know yourself and you acknowledge what's going on. Yeah, I tell you, between the pain syndrome, which is frequently associated with POTS, and Dr. Kinsella touched a little bit about it, I mean, we need to break the cycle of codeine. It is a disaster. If you have POTS and you use codeine for pain, you will have more GI symptoms, you will feel more bloated. All the opioid decrease gastric motility. So imagine that. You were feeling bloated before, you're going to feel even more bloated. So natural supplements, different things that you can do. Muscle ache, it's another thing that happens with POTS. Take magnesium, it's over the counter, or ask your physician to fill a prescription for magnesium. CoQ10, all these more natural things that you can do. Avoid, you know, white carbs. That's another thing that really will make a difference. And really overcome this whole deconditioning continuum. As Brad says, don't set goals up here. You're not going to run a marathon or half a marathon. But be involved with community. You can walk in the mall if it's winter. You know, you can do the stationary bike. You can do a lot of things to overcome the deconditioning. So, you know, touching on this bariatric, which I already mentioned before, everybody wants to be in great shape, but be aware that the rapid weight loss, the hypocaloric protein diets will create abnormality in your autonomic activation system. And that starts happening right when you get put on a liquid diet before you go for surgery. So be aware of this possibility if you embark into that situation. Even in the military, we have a huge bariatric population, and really you have to do counseling with these patients before they go into surgery. I have 3 girls that are going to go ahead and do it, but know that your medication regimen will change, that you have to be aware of your blood pressure is going to get lower. So if you were an antihypertensive, you need to know that you probably will come out. You may have a rebound situation, you might have rebound tachycardia. So be in contact with your physician and be honest, as Brad said, talk about your symptoms. There's no shame about POTS syndrome and symptoms. And again, stay away from the trigger events, the precipitating factor. You know, we really want to ask everybody, sometimes it takes a long time the first time you meet a POTS patient. It's interesting that people already know that there is something wrong with them, and so, but you really have to sit down. If it's a kid, with the parents, if it's an adult, and ask the question and see what has been experienced. Because this is not a diagnosis that happens today. It's something that has been going on for quite some time, and so the patient is aware that something is wrong. And of course, you know, you want to do a thorough physical exam. This fact that you can see this POTS patient, especially the kids with sweaty palms, you know, fast heart rate, you stand them up, the heart rate is 120, you already know that is a POTS patient. And then the school labels them as hyperactive, or they say they're lazy, he's not doing his homework, he's not paying attention. That is not the kid's fault. So anybody who's a parent who has young kids, think of that possibility, because we try to label kids very quickly, and sometimes they're not lying when they tell you that they're not feeling good. You know, anemia is another factor. A lot of these girls that have very heavy menstrual period, they don't drink water, they feel horrible. And then you find out, I had one at St. Charles that I saw, and she was really having an amazingly horrible symptom. Usually we don't necessarily run H&H on all these young kids because you assume that the pediatrician has done that. And then we randomly run hemoglobin and the kid was like 7.5. So not only she had POTS, but she was extremely exacerbated by the anemia. So think about supplementing vitamins, vitamin D, iron, and things of that sort. So that's why laboratory exam is important. And then, well, of course, the evil till table. How many people here have had a till table? A lot. Yeah, it is not a very friendly test, but it's so important. So if you're told about till table test, you know, we have booklets, we prepare you, and what we've been doing lately, especially where I work, is to have you get a couple of liters of fluids after you get your till. We really didn't do it here much because of the fact that, you know, we're cramped in time and really we kind of move along, but we have an infusion service there, we're on the same floor, so we can tell people, let me get you a couple of liters of fluids, at least you walk out of here feeling human, rather than, you know, feeling horrible after you go up on a till table. Sodium water intake, I'm not going over again all this conversation, but we want at least 3 grams of sodium, 3 liters of fluids. So that's what you need. Whichever way you want to eat it, it's fine. You want to take, you know, there's a cute spoon on the table. You want to fill that 3 times a day with salt? Go for it. It's a nice little size full gadget. You know, kids, they want pretzels, go for it. It's better than something else, you know, but away from junk food. If you know that it happens when you stand up, please do isometric stuff. Start moving your legs before you get up. Especially if you're in a classroom, in a conference, or people that stand up all the time, like this will do. You move your legs, because otherwise, especially in formation, you know, especially another activity where they have to stand for a long time, boom, down they go. And I have spent a lot of government money lately in buying support stockings. I think Orlando is going to fire me because I'm on this stuff. And I tell the guys, put them under your green socks. Nobody will know. But we want the support garments. Those are important, really, especially if you have venous pooling and vasoconstriction. It's put them on. There's nothing shameful. If you want them, the girls can wear the cutesy ones. I even bought some for myself. They're pink and ugly, and I got them on Groupon for 17. 3 pairs for $17. They're okay. And then exercise training. Everybody who's seen me or Dr. Kinsella and I think other people involved in the community. Dr. Levine, who is an exercise physiologist who worked at the University of Texas, he has actually a protocol for POTS patients. You know, we usually give it out to everybody as an informational package, and it tells you how to start. Don't start with aerobic stuff. That's not good. Start with floor isometric exercises and move on to the actual running, bike, and so forth. Because otherwise, I mean, if you're tachycardic, running on a treadmill is not the best sport for you, for sure. So, you know, sometimes you have to tell people. I mean, I see guys that, and one thing that we've been doing, and I don't know, a lot of cardiologists, I don't know how many cardiologists use this is a little sticker thingy called Zeo Patch. Unfortunately, most of them are not paid by insurance because it's too new, and it's a wireless monitor. You put it on for 2 weeks, and it gives you beat to beat, and so we can follow, especially the trainees, and see how high the heart rate goes using a particular phase of the day. You can see people that have POTS, they get up in the morning, they don't do anything, heart rate is 120. It's like, what were you doing at 5 o'clock? Oh, I just got out of bed. You know, so there you can see the day-to-day variability of the heart rate and try to correct it. A lot of times I tell people to take their beta blocker at night, so when they get up, at least they have some correction of their heart rate. Beta blockers, it's our friend, although some people don't like it when you get tired, you need to give it time. There are some people with asthma and some people really cannot tolerate beta blockers, but for the most part, you know, propranolol, Toprol XL with extended release are good medications. Florinef We tend to use it more in kids because it increases volume retention. Women, especially in childbearing age, it's a bad drug. You feel like you're PMSing all day long, so it's really not particularly user-friendly. Makes you bloated. You have a big issue with Florinef, especially in young people. You lose potassium, so you need to eat bananas, which are not good for migraines, but you have to take potassium tablets because your K will drop. I've seen a couple cases where they were not told about the potassium, and they showed up with a K of 2.5, 2.9. Obviously not good. So it's important for anybody who takes Florinef to know that it will drop your potassium. Please eat fruits, bananas, and whatever else you can do. The midodrine is another, thing to have, trick in the pocket. It has a very short half-life, less than 6 to 8 hours. So if you have episodes where you're hypotensive, midodrine 5 to 10 milligrams, 3 to 4 times a day, you can use. Do not take it before you go to bed because there's no reason to. And actually can give you high blood pressure for that period of time. So lastly, during the day, there's 2 drugs that are not FDA approved for POTS, but we use them often. And one is Northera. It's a dopamine receptor drug. It's used for persistent orthostatic hypotension. It's mostly indicated in people that have secondary neurological condition in which you have persistent hypertension. And then Corlanor is a new drug released for tachycardia, mostly in patients with congestive heart failure that cannot respond to beta blockers. It's very, very good for people that cannot take beta blockers with POTS. The heart rate gets significantly better. I had a girl in Orlando, we gave her, she was probably 110 pounds or less. She was on so much beta blocker, and she had a loop implant, and her heart rate was 130, 120 all day. We finally switched her to Corlanor, and she did great. Felt way, way better. So, it is complex to get prescription for those things. If they're not covered by your insurance, but your cardiologist or neurologist thinks that you can have it, it has to be filled on special formulary prescription, and it goes down a long list of pages that needs to be filled out by the doctor. But then you can mail it to your pharmacy and can be picked up there. So those are 2 drugs that Corlanor in Europe has been used for POTS for probably 15 years. Not so much in the States. The things that we find that are very kind of frustrating is because it's a diagnosis that a lot of people don't know about, there is a lack of patient education. So patients can't tell you, or they don't go to the doctor and say, oh, I think I have POTS. They will tell you, I don't feel right. But as a physician and nurses who screen patients, primary care, home care people, be aware that this is a real diagnostic potential, especially in women of a young age. Also, set realistic expectation, as Dr. Kinsella said. I'm not a good wife, but if I could be a good wife, I would say, set realistic expectations for everybody, for family, for patients, for yourself, because you guys think that you feel horrible. We do too. If I have a patient that I care for and I really can't manage that patient fully, I have the same level of frustration. We want our people to feel good. We want our people to be in a situation they can function. The girls, I have all these teenagers, they can go to prom without passing out. That's a big thing. A lot of these girls are terrified. Oh, I'm going to wear high shoes. I'm not going to, boom, down they go. Or playing sports. I mean, boys are very, stuck on looking good on the field, go play football, go something, pass out, basketball, pass out. So make sure that you have set goals for them and work your way up slowly. There is frustration, and remember the symptom amplification. Kids, have them see a counselor, have them involved with the community. in the schools, we are really trying to spread the word in the school communities everywhere. So they will let these kids go pee. I mean, that's another issue. Some of the schools are like they only have 7 hours to go to the bathroom. That's crazy. Or no water during like hours a day. That's crazy. I mean, I have to write letters. The homebound program is very important. If your kid is limited by symptoms, please go to your school district and fill out the homebound forms. If you're a nurse involved in the community and you have kids that you care for, go as a mom to dad, go, get the homebound forms. Because you don't want a kid to be 2 years behind, in high school or elementary school because of these symptoms. It's important. College is the same thing. So all the kids that we see that are in college, getting ready to go to college, awareness. And, it is a mixed bag. So you can have, EDS and have POTS. You can have celiac syndrome and have POTS. You can have Crohn's disease and have POTS. You can have, neurological disorders and have POTS. So you have to trust and you have to really talk openly to all your doctors, have open communication between the different specialties. So we don't give you some crazy medication that doesn't work for something else or take, I'm always very thorough to go through the list of meds of all the patients we see, and that's very important. So, and again, same menu does not work for everybody. So be aware. You can have midodrine and Celexa. You can have beta blockers and Corlanor. You can have both. You just have to titrate your drugs for your symptoms. So customize the treatment. That's a key. And you can have a bunch of drugs that you have at home and don't use every day or every week, because you want to be functional. That's very important. So, and empower the families. Those are your people. Those are your people. So ask for help. Be aware. Family and friends are very important. PRN medication. I mean, a lot of people have nausea, they have GI symptoms, so have Zofran if you need. Don't overuse it, but be aware that you can ask for some sublingual Zofran if you have a really bad week of nausea. Don't abuse pain medications. That's a key. If you have migraines, there's going to be a rebound. Make sure that if you have a lot of these weird symptoms, as Dr. Kinsella said, these pseudo TIAs or transient episodes, make sure also that you do not have an organic reason for it. We see people with, we had actually the wife of a physician a couple of weeks ago. She had very intense migraine. She actually had a true TIA. She had POTS. Nobody did an echo. We found out an ASD that was 2.4, almost 3 centimeters high. We sent her to Barnes. She had her, PFO, ASD closed, migraines went away. They're rare cases, and you have to have a real TIA before they close it. But those are things that can happen, and we as cardiologists want to look at those stuff before we label you. Oh, there's nothing to do. Exercise. As I said, get involved with yoga is very important. Down-regulate your other nervous system. Chill out. Music therapy, art therapy. If lights is a trigger, don't go without sunglasses. Don't drive without sunglasses. We have a lot of people that come in and says, "Oh, I feel so nauseous when I drive with POTS." I'm like, "Yeah, you don't wear sunglasses. There's a bright light at night. You can be triggered by the traffic light, by the traffic on the other direction." So, support group. We're fortunate in St. Louis to have this group. People work together. There's a lot of online education, and then again, down-regulate yourself. So, there is these things that we already talked about: it, transition to college, homebound for students, school, sports participation. Coach needs to be aware of what happens Pregnancy can be a lifesaver because your body status increases, or it can be a disaster. So if somebody's pregnant, hyperemesis, vomiting and vomiting, always your bone status is not going to be good. So those girls need to be followed here. There are some girls that are great in pregnancy, and it's fantastic, but sometimes we use beta blocker. Propranolol is not the most fantastic drug, but a lot of the OBGYN will let you take it until the end of pregnancy. There's some risk of low birth children, but it's very minimal. And then last, this is mast cell activation syndrome. Be aware that mast cells are located in the vicinity of the nerve and the blood vessel, and the symptoms can be organ specific. So you can have mast cell release in your gut, you can have it in your bladder. A lot of the cases that used to be thought to be interstitial cystitis are actually mast cell induced issues. So consult your specialist or urologist if you have any of these symptoms to be guided to the right medication. For the functional GI disorder, bloating, dyspepsia, IBS, the gastrochrome is one of the drugs that can be used successfully. It's expensive. Some insurance will not cover it. You can start titrating your patient from 600 all the way to 1800 milligrams a day in severe GI symptoms, and then stay away from gluten. The diet is so important. Junk food is enough. You gotta get rid of all of it out of your house, out of your refrigerator, and eat basic, healthy food. For the mast cell activation, use aspirin, H1 and H2 blocker, and they can be used as needed. Digamet, aspirin, Atarax, those are drugs that some of it my patient and myself symptoms use at the time of their episodes. You can also consult, allergy and immunology services. They can help you with that. They can do biopsies. They can do all sorts of things to really identify what kind of MRCS syndrome you have. And so again, the tree is a must, as my friend Brian already showed. You are up and down, but you are the same person. Don't lose hope. Root yourself in who you are. Your symptoms can be bad one day, they can be good another day, but it's still you. Don't lose your expectation for a great life. Keep loving your family. Keep hanging out with your friends. Don't isolate yourself. That's really a difficult thing. The storm can come and go. There's never a storm can last forever. And as I said, anyone who says sunshine brings happiness has never danced in the rain. So you guys can be happy and have happy lives, and do the best you can, and use your good days to enjoy life. This is not certainly granted to everybody, and especially where I am now, I can tell you we see a lot of young life gone in an RV. So enjoy, and I really want to thank all of you for being part of this community and allow me to be part of your community, and best for everyone, and thank you.